Hello, good day to you. So today I will be discussing basic principles of hand examination at the undergraduate MBBS VIVA level. So in MBBS exam, most of you may not get a hand case, but some of you might get a malunited distal and radius, or you might get a flexor tendon injury, or a nerve injury, or arthritis, or even sometimes you might get a rheumatoid arthritis case with deformities. You might also get some infection like an osteomyelitis. So these are the cases that you will get at your undergraduate VIVA level. So you must know the basic principles. You must know how to examine a hand, and you should also know how to examine a wrist. So it's not very difficult. So I'll just cover it in short. So you should know that the history, you should ask what the age is. According to the age, various diseases, like for example, arthritis will be seen only in old age. And you should always ask the handedness, if the patient is a right-handed or the left-handed. So accordingly, we need to change the management. Uh, if it's a dominant hand, we need to give the best treatment. Suppose there is a minor fracture, also we need to treat it. If it is a non-dominant hand, if the patient is an old age, sometimes if it's a Colles fracture, we can just conserve it, don't do anything and just give a plaster cast. And always ask the occupation. Now suppose a patient is a painter, and he has a problem with his median nerve, so we need to treat it. We can't just let the median nerve be alone. And similarly, the ulnar nerve, which is also called as a musician's nerve. So painting is more requires the ulnar nerve more, even a musician. And whether as a laborer, he requires the median nerve more. So this occupation also has an importance in the history. You should ask for it. And smoking history is basically for wound healing. So if the patient has any operation, the patient has any infection, so smoking will interfere in his wound healing. And if the patient has an injury, so you must always ask about the details of the injury, like whether it is a crush wound, whether the sharp penetrating wound has gone. Sometimes you may have a vascular injury or vascular damage. So that also must be ruled out. And position of the hand at injury is very important when you want to rule out a Colles fracture. Sometimes you have a fracture of the distal and radius, which could either be a Colles fracture or a Smith's fracture. So Colles fracture is nothing but a dorsal displacement at the end of the radius. So you have six components of Colles fracture: a dorsal tilt, a dorsal displacement, a radial tilt, a radial displacement, impaction, and supination. So these six components happen when you have a fallen and outstretched hand. That is why you have to ask the position of the hand at injury. Whereas if you take the same thing in a Smith's fracture, the patient will have a volar tilt and a volar displacement, but a radial tilt and a radial displacement as well. So these are the components of a Smith fracture. Accordingly, a Colles fracture will lead to a dinner fork deformity, and a Smith's fracture will lead to a garden spade deformity. So in the upcoming slides, I'll just show you a photo of what each deformity means like. And accordingly, uh, we can diagnose it even without an X-ray. Now, the time of occurrence is important because if you have an infection, and you should know whether it's a flexor sheath infection or not, you should treat it. You should open the wound and drain any pus or abscess. So that is why you should also ask the time, and also the time of injury if relevant. So if there is too much hematoma, you cannot put a plaster cast, because a plaster cast will only add to the tightness. Or suppose the patient has too much swelling, you can't put a plaster cast. Now the difference between a slab and cast is slab is covers only half the circumference, whereas cast covers the entire circumference. So if the plaster cast is too tight, then the patient will have a distal swelling. Or suppose the swelling reduces, then the plaster cast will become too loose. So these are the things you should take into mind, and also ask whether the patient has any injuries elsewhere. Now, you should ask history of diabetes, cardiac or pulmonary or renal disease, and any prior surgical history. So now, one by one, we'll just see the important points in the history. In history, you should ask for the pain. Now, pain can be either because of injury, it can be because of infection, it can be because of something known as a reflex sympathetic dystrophy and arthritis. So you should ask the aggravating and relieving factors. You should ask basically what activity is restricted, whether the patient can hold a spoon, whether the patient can lift up any object, whether he can grasp, and whether he has any guarding of his wrist and hand. Similarly, swelling is important. Swelling can be, you can have swelling with infection as well. So you should rule out swelling because of pain, because of injury, and swelling because of infection. So uh, he'll have fever and raised temperature in an infection case. And you should also see whether there is any deformity. Now, patient can have any deformity in case of an rheumatoid arthritis. He can have loss of function. That also is important because you should check each kind of function, whether he can do a grasp function, a pinch function, or a hook function. So all these functions also have to be tested. In addition, you should always see the patient whether he has a loss of power. So I think we've covered all the history points, previous hospitalization, and details of trauma, dominant hand, and activities of daily life. So you should always mention to the examiner that the patient could do this and now he can do this. So let's move on. In the examination of the hand, you have inspection, palpation, range of motion, the various muscle and tendon function, the neurological testing, the vascular assessment, stability testing, special testing. So these are important aspects in the hand examination. So one by one will come. Now inspection, you should always have a good exposure and expose the patient right up till the elbow. Sometimes the patient wears a full sleeve shirt, so always unbutton that sleeve and expose it right till the elbow, and always compare the normal hand. You should see the fingers cascade. So this fingers cascade is there in the next slide that we'll see. See if any deformities are there. See if there is any muscle atrophy, swelling, and scars. And also you should see for sinuses if there's any infection. Also see for trophic changes. Now trophic changes are when you have something like loss of hair, shiny skin, loss of the nail pigmentation. All these things should be checked for trophic changes that can be seen in either leprosy or diabetes or peripheral neuropathy. So do check these trophic changes. Now let's see what this finger cascade is. So when you tell the patient to do this kind of position, you should see that all the fingers generally in a normal patient, they will point towards the scaphoid. The scaphoid is over here roughly. And if the fingers are deformed, they are malunited, or there is some deformity or even pain, so the patient will not keep it in this attitude, and then you will know it's abnormal. So this is a normal alignment. Just see this and you should know. Now, in the dorsal aspect, you should always inspect the nails. Nails can have vasculitic changes. They can have a local infarction in rheumatoid arthritis. They can have splinter hemorrhage or telangiectasis in SLE and scleroderma. You can have pitting of the nails in psoriasis or hyperkeratosis, onycholysis, discoloration. You can have this uh, ridges. You can have anemia. In anemia, you can have this spooning of the nails, and you can also have infection of the nail folds like paronychia, subungual hematoma, or even dilated capillary loops. So most of these things will be covered in dermatology or medicine, but let's get to the ortho part of it. So you should always see whether there is any sausage shaped digits. That's seen in psoriasis. There is something called as arthritis mutilans, that is also seen in psoriasis. And there is something called as swan neck deformity and boutonniere deformity, that is seen in rheumatoid arthritis. Herbert's nodes are seen in osteoarthritis. Garrett's pads are seen in violin players, but can also be associated with Dupuytren's contracture. Now, there is something called as a benediction attitude, which is seen in median nerve palsy. It is also called as an ape thumb deformity. You can see clawing of fingers in ulnar nerve palsy or in leprosy. Contractures can be seen in Burns patients or in Dupuytren's contracture. You can see telangiectasis. You can see a cyst, sebaceous cyst. Look for appendages and look for hair loss. So all these things need to be examined in your inspection point of view. In your you also see your knuckle pads, see any shortening of metacarpal, like shortening of fourth metacarpal is seen in Turner syndrome, so don't miss those things. See whether there's any wasting in the first web space, wasting of the introshi, and see if any carpal bossing. Now in the radial aspect, always see whether the patient has any swelling, because he can have something called as a gamekeeper's thumb, which is an injury to the ulnar collateral ligament. He can have, it is also called as a skier's thumb, and in arthritis of the first metacarpophalangeal joint, he'll have swelling. Now, there is this anatomic snuff box, so always inspect that. The boundaries of it are the extensor pollicis longus and volarly by the abductor pollicis longus and the extensor pollicis brevis. So inspect that anatomic snuff box, because that is where the scaphoid bone is, and if there is any scaphoid fracture, the patient will have any tenderness there. But of course, that's in palpation, but do inspect it as well. And also inspect the pulp spaces of the fingers, see whether there's any Raynaud's phenomenon, see whether there's any swelling, and you can see for palmar skin pits, see for Dupuytren's contracture, and Canavel sign. Canavel sign is nothing but a fusiform swelling extending along the metacarpophalangeal and the along the phalanges, because that is the sign of infection. So that look out for Canavel sign. I'll show you a picture in the upcoming slides, and see whether the tendons are working. See whether there's any loss of the power of any of the tendons, like the flexor tendons. Okay, and see for wasting. So wasting can also be seen in leprosy, can also be seen when you have an ulnar nerve injury or prolonged misuse or this prolonged disuse of the hand. And now let's just see the main aspects. So if you look, always look from the side also, see the nail bed, see whether there is any infection. Like I said, there is any thinner wasting or whether there's any hypothinner wasting. Look out for scars, sinuses, look out for ridges, look out for signs of vitamin deficiency, look out for any injuries, any deformities you can see in the wrist, or any deformities you can see in the thumb as well. So remember that the thumb has only one interphalangeal joint. So if at all you get any pain, should look out for this over here. Look out for, there is something called as an intersection syndrome. So intersection syndrome is basically there are two muscles here, abductor pollicis longus and extensor pollicis longus. So where they intersect, that point becomes painful. So that is called intersection syndrome. So see if there is any pain on moving when the patient moves his thumb. See about that. See any clicking sound comes or not. Okay. So now I'll just show you a few images. Now this is a patient of a tendon injury, and he has lost his flexor digitorum superficialis of the index finger. So because of this cut over here, you can see that that it is a penetrating injury. This tendon is damaged and we need to repair this tendon. So look out for such telltale signs. Now, this is a case of a mallet finger. So mallet finger is a case of ruptured extensor, tendon injury. So because of this extensor tendon rupture, the patient is not able to do a distal interphalangeal joint extension. That it is called as a mallet finger. So this is how the schematic diagram. Suppose the patient loses his extensor tendon over here, and he'll get something called as a mallet finger. Now, this is a similar picture. Now, it can also, Now, this is a picture of a claw hand, ulnar claw hand, because the patient has had an ulnar nerve injury. So his medial fingers are in a clawed position because the ulnar nerve is not working here, right? So this is a claw hand. Further, now this is a picture of this arthritis mutilans, which happens in psoriatic arthritis. It's one of very debilitating diseases, and the patient can't use his or her hands. So this is something like that. These are Garrett's pads. Garrett's pads are seen in, like I said, violin players because of constant use, or they can also be seen along with Dupuytren's contracture, which is palmar fascia. It is thickening. Now, this again you can see in rheumatoid arthritis. This is how rheumatoid hand looks like. You can see various thickening. In rheumatoid arthritis, you can see two types of deformities. One is a swan neck deformity, and one is a boutonniere deformity. So now boutonniere deformity means hyperextension at the distal interphalangeal joint. So I'll just show you. So if you look, this is your boutonniere deformity. This will be like this. You will have hyperextension at the distal interphalangeal joint and hyperflexion at the proximal interphalangeal joint. So it's as if you're pressing a button. When you press a button, this is how your finger becomes. And the same thing in the swan neck deformity, you will have hyperflexion at the distal interphalangeal joint, whereas you'll have an extension. May or may not have hyperextension, but this is how a swan's neck looks like, right? So don't confuse the two. Boutonniere like this, as if you're pressing a button, and this is a swan neck deformity. So that is there. Then the next thing what I wanted to show you is this deformity. Now this deformity is seen in Colles fracture. This is called as a dinner fork deformity because it looks like a dinner fork. So the opposite is Smith's fracture, which looks like a garden spade. So that is called as a garden spade deformity. Now see, this is what is on your screen is a dinner fork deformity, and the next slide, this one is a garden spade deformity. Okay, so basically there's a volar translation in this, and the previous one there's a dorsal translation. Okay. Then this is Canavel sign. Canavel sign is a fusiform swelling around in flexor sheath whenever you have an infection. So that is indicative of infection, right? You'll have a sinus here, you'll have fusiform swelling and painful flexion of fingers. This is a leprosy hand. You see there may be a total or partial loss of the digits. You can see loss of ridges, smoothing of skin. You can see atrophy. You can see even hypothenar eminence atrophy. Sometimes you may get a claw hand in leprosy, and most of the time the nails are not in good condition. So that's leprosy. Now you come to the palpation. Palpation, always you see the temperature and the tenderness. You see whether there's any dryness. Okay. So if you have a nerve damage, you can see the trophic changes, which is anhidrosis. Now you have to see in carpal tunnel syndrome, you can get a thenar eminence atrophy, whereas in ulnar nerve compression, you can see a hypothenar eminence atrophy. In Dupuytren's contracture, you can see a palmar aponeurosis. So palmar. See, this is the palmar aponeurosis. In Dupuytren's contracture, you can get a thickening of this palmar aponeurosis. In thinner eminence means this. So in carpal tunnel syndrome, you'll get a thinner atrophy. Whereas ulnar nerve, so there is this canal over here, which is called as Guyon's canal. So ulnar nerve comes from this Guyon's canal and supplies this hypothenar eminence. So if either the ulnar nerve is trapped over here in the Guyon's canal or it is trapped in the elbow, it can cause atrophy of these hypothenar muscles and can even cause a claw hand. So these are the problems with ulnar nerve. Okay, so you can have a radial claw hand as well, that is seen in medial nerve, or you can have a combined claw hand, right? So you should see that. Always palpate whether there is a nodule over here, finger sheath nodule, and see the range of motion. Now you should know this range of motion. In the metacarpophalangeal joint, you can have 85 degrees of flexion. In the proximal interphalangeal joint, you can have 110 degrees of flexion. But in the distal interphalangeal joint, you can only have 65 degrees of flexion. So that total flexion may be 260 degrees, but you should know these degrees at each thing. Compare it. I mean, you don't have to write it in your exam, but if there is anything abnormal, then you write it. That this interphalangeal joint is not, it is moving only these many degrees. Okay. And if you should not normally have any extension, but if there is any extension, it could mean a tendon is ruptured or the patient could have an hyperelastic body as seen in Ehlers-Danlos syndrome. So these are the things in palpation. You have to always make the patient tell the patient to make a fist and then open it accordingly. So in that single movement in within a fraction of a second, you can make out whether the patient really has any deformity or any clicking sound as seen in trigger finger or any tendon injury. Okay, so trigger finger, the patient generally has a click like this. and it's because of a tightening of a finger tendon sheath. So see if the patient has that, and tell the patient to do this method, the abduction and the adduction at the metacarpophalangeal joints. That's a quick way of assessing the range of motion. If there is any abnormality, then you document it. Otherwise, you can just say that the range of motion is normal. That's in your exam for a quick to save time. And neurological testing is important because you need to check the pinprick, you need to check 2-point discrimination, you need to see all the nerves, median, ulnar, and radial nerve. This is the sensory distribution of all the nerves, and you can see that the radial nerve supplies now the dorsal aspect of 3 fingers, whereas the median nerve supplies this aspect. What is shown in the picture? Just go through the diagram. Okay, I won't go into too much details of this because you studied this in anatomy, but just know this dermatomal distribution, and this is how the nerves supply. Next, you should check all the sensations in all these areas. If there is any loss, you know that this nerve is damaged. Right. So you should, suppose you want to check the median nerve. This OK sign is very important. In this OK sign, you can check actually all the 3 nerves, as in the median nerve causes the flexopolysis, the ulnar nerve causes the adduction, and the radial nerve causes the wrist extension. So in this one action, you can check all the 3 nerves are working or not. Now, this is a way to check the flexor digitorum. You have to make lock the other fingers, see that they don't flex, keep them in extended position, and ask the patient only to flex the middle finger. So that's a flexor digitorum superficialis you're checking. And if you want to check the FDP, so you have to block the action at the proximal interphalangeal joint. So that way you're checking only the flexor digitorum profundus. Here in the right picture, you're checking the flexor digitorum superficialis. So see whether the flexor pollicis longus is working or not. Ask the patient to do this action, the thumb movement, and that way you're checking the flexor pollicis longus. So check each finger if it's working or not. Check the opposition. Now, ulnar nerve, you need to see whether the patient has abduction and adduction at the fingers. So there is this paper test, which is also called as a card test. So card test will basically check your adduction, which is caused by the palmar interossei. Whereas now what is shown in this diagram is called as the Igawa's test. The Igawa's test, you're telling the patient to spread his fingers apart. If he's able to do that, that means the dorsal interossei are intact. That is called Igawa's test. And if you check the card test, you're telling the patient to adduct. So that is the part of the palmar interossei. The work of palmar interossei is to adduct the fingers. Okay, so the patient can clasp a card between his middle and ring finger. Okay, that's a card test. This is to check the median nerve. You're telling the patient to touch the pen as in this position. So if he's able to do that, the work of the opponent's pollicis is working. That means the median nerve is intact. So that's a pen test. Okay, if the patient doesn't have a medial nerve, this is how his hand will look. This is called as the ape thumb deformity. Okay, and what it'll also have is the pointing index. So median nerve injury will have a pointing index. So that is called the sign of benediction. So if you've seen a priest at a church, if he like when you have a christening ceremony, he makes his finger like this. That's why it's called a sign of benediction. Okay, not this picture, but just imagine a pointing index. Now you have to check thumb adduction as well. Okay? There is something called as a Froment sign. The Froment sign is used to check uh, adductor pollicis, and that's seen in ulnar nerve palsy. So if you tell the patient to hold a book and he's flexing his thumb too much, then it means that the ulnar nerve is damaged and he cannot use the adductor pollicis. So that is Froment sign. Okay, and also you should check whether the patient is able to extend his wrist. That is called as a wrist drop. If you're what is in the picture, the patient cannot extend his wrist. That is called as a wrist drop. That is seen in radial nerve injury. Always ask him to do this. If he can't, then you note it down. Now the vascular assessment, you have to see whether the vascular is damaged. Now this is the radial artery, this is the ulnar artery. Generally, if one artery is damaged, the other artery takes over because the patient has a collateral circulation. But sometimes the patient does not have a good collateral circulation. So then his hand becomes cynosed when you do this particular move. This is called as the Allen's test. So in this Allen's test, he's clamping even the radial artery, even the ulnar artery. And then after some time, what will happen is his whole hand will become purplish or cyanosed. That is called as Allen's test when you don't have a good collateral circulation. Okay. Also assess the pulse. You assess the color of the hand, capillary refill, temperature, see the pinprick sensation. Okay. Now you come to the skeletal assessment. You see the swelling, deformity, tenderness, and abnormal range of motion. Coming to the last part of this thing, you have to check the stability. Now, if you have a wrist injury, so you will have to check the stability. Now, if his ulnar collateral ligament or the radial collateral ligament is damaged, so use the wrist, and suppose this is the patient's hand, to do movement at the wrist. If the ulnar collateral ligament is damaged, he'll have more of the radial deviation and vice versa. Check these things. Now, there is something called as a de Quervain's disease. De Quervain's disease is nothing but your pain at this tendon. Okay, the same tendon, the abductor pollicis longus and the extensor pollicis longus. Okay, sorry, the abductor pollicis longus and extensor pollicis brevis. So when you do this particular movement, the patient's tendons get stretched out. Okay, just like is shown in the slide. And when you have a stretching out of these tendons, the patient gets a pain, because this de Quervain's disease is nothing but a tenosynovitis. When you have a less space for the flexor, for the extensor tendons, they get pain. Therefore, this movement, de Quervain's disease, that is called as a Finkelstein test. Now, Palin's test is test for the carpal tunnel. So you make the patient, tell the patient to do this particular movement, because the median nerve is under pressure, that can have pain. A patient can have pain, or if not pain, he'll have a sensory loss in the area of the median nerve distribution, the 2.5 fingers. So that he will tell. Okay, so that is called Palin's test. And you can also have a reverse Palin's test, right? So Palin's test and reverse Palin's test, tell him to do that. And after 30 seconds, if he has a sensory loss, you can tell him that you have a median nerve compression at the carpal tunnel syndrome, at the carpal tunnel, I mean. So Tinel sign is when you have a nerve injury, you're checking for any tingling in the area of the nerve distribution. So that when you tap the area of the nerve, he'll have tingling in the distal area. That is Tinel sign. And this is a Durkheim's compression test. You just compress the patient at the carpal tunnel. So if he has a compression at the carpal tunnel or carpal tunnel syndrome, he'll have a median nerve distribution, sensory loss. So again, all these three signs were for carpal tunnel. The Palin's test, the Tinel sign, you're tapping the nerve and you'll get sensory loss, and the compression test, direct compression test at the carpal tunnel. So these three signs will detect carpal tunnel syndrome, right? Let's summarize. You have to ask a good history. In the inspection, see for deformity, atrophy, swelling or scars, and see whether there is anything on palpation, any deformity. See all the range of motion, see the muscle and tendon function. Neurological testing is important, vascular assessment is important, and along with the stability testing. So that's the gist of the hand examination. There is much more to learn. But I think for undergraduate level, this should be more than enough. So I've just tried to give you the main points. So if you have any doubts, you can always ask me in the comment section. Thank you.